Welcome to SNUH Cath Lab. I'm H.S. Kim. My co-operator is Dr. J.Q. Han, Ji-Hoon Kang, and Hae-Chan Jo, and Do-Yeon Hwang, and specialists. Let me introduce the first TAVI case. 89 years old male with recurrent syndrome, syncope, plus BMI is 23, plus intermediate surgical risk, plus normal chest X-ray, but ECG is problematic. First degree AV block, or sometimes complete AV block, plus wall motion is good, plus valve area 0.8, Vmax 4.2, plus asymptomatic coronary lesions, plus valvular calcification is moderate. So Agatston calcium score is 2400, calcium volume 18 cubic millimeters in non-contrast, moderate to severe grade, plus annulus LVOT is free of calcium 23 and 22, plus sans valsalva wide 30 or 28, as the junction is also 30 wide with calcium plaque, plus coronary height is 16 in both sides, as the junction height is 20 or 23, plus membrane septum is short, 4.4, thus conduction problem is the issue in this patient, plus three-concept view is main view, it's good angle, plus iliofemoral artery is tortuous, plus to summarize measurement, the annulus is 20 by 26, mean 23, annulus area is less than 430, small annulus male. Otherwise, no problem, plus when you select one valve out of 4 in Korea, I always consider 9 clinical situations. In these patients, there are 2 factors, risk of AV block and small annulus requiring wider orifice area. In this aspect, I think accurate neo is the preferable valve type. Plus, we chose 25 millimeter accurate neo. Actually, its landing zone diameter is 28, leading to 20% oversizing. That is my favorite digit. Plus, this is 25 millimeter accurate neo valve. 25 is waist diameter. Actually, low crown landing zone diameter is 28. Landing zone is 7 millimeter among 15 lower crown height. Plus, the beauty of this valve has several merits, especially for these patients. Supraannular valve provides wider orifice area. Plus, when we compare the accurate and the sapien in some small studies, both are similar to each other in leakage, but mean gradient is definitely lower with accurate neo than sapien. Thus, ppm incidence is lower with accurate than sapien ultra 3. Plus, when you compare accurate and Evolut, only safety profile is better with accurate because of the low instance of permanent pacemaker implantation. Plus, recently there is a head-to-head comparison of accurate Neo 2 versus sapien 3 Ultra from 4 German centers. They recruited 1,300 patients, then matched and they prepared 472 pairs of accurate Neo or sapien 3 Ultra, plus result here. 1 month pacemaker implantation rate is 8, accurate 10% in sapien. Plus, the small annulus in the male patients, risk of AV block, tortuous iliofemoral artery, suggesting the choice is accurate neo. Let me introduce the pictures that I've taken just ago. Andrew, please. Here, this is a three-cursor view. We can see the calcium calcified valves plus. This is a cusp of blood view. Then, can you see the hemodynamics?
Of course.
Yes.
Okay, now we are going to do 역시 또 세게 했군. The procedure by inserting sapphire wire to LV and pre-ballooning with 21 millimeter valve.
I'd like one question. Actually, when you use the accurate neo, oversize index is 20. Is the 20% oversize? Maybe there is some possibility to develop the rhythm disturbance, particularly in this patient. And second one is when you do the accurate neo, predilation is needed. In the fluoroscopic image, and the Agatston score is more than 1,000. There is some more probability of the sudden acute AR during predilation. So, what size of the predilation? When you will you do
They
the
recommend just
sentinel?
1 millimeter less than the average annulus diameter, but I think it is too aggressive. Thus, I always choose the balloon size 2 millimeter less than average diameter.
You do not use a sentinel.
No,
Okay.
already 89 years old male.
This is a very good demonstration for the development of the complete AV block during a procedure in the accurate neo or not. It's a very good demonstration.
자, pacing 준비. Okay, pacing on. Inflation. Deflation. Off. Okay. Better.
In your slide presentation, actually, this patient is a small size of annulus, but you compare the measurement in the four company, and the Boston size of the annular size around 400. The other company measured it around 450. So, do you strongly believe that the 400 measured by Boston is sure? Maybe.
I always compare the data from four companies,
Yes.
and I follow the majority.
That is a good way to select, but the Boston is the smallest compared to the other three company. It is really minor.
It seems that after balloon dilatation, conduction disturbance develop.
So, best angle? Okay. Can you see the free cell? Okay,
Yes.
the free cell adjustment is very good. Starting point is exit is 6 o'clock, but that usually change. Okay, I advance the system all across the arch. Okay, now the free cell appears both sides. It may change during advancing. Thus, I just put the whole system at the level of the annulus. 조정하고. 여러분 어때? Good?
네.
Okay, we can see the free cell on both sides, a little bit bigger on the left side. Thus, I have to turn the system a little bit counterclockwise rotation. Test it.
네.
To give. Test it. Okay, good. The pigtail position is not good, because I'd like to change the position of pigtail, not to overlap the system. does not move. Okay, free set position is good. Then, arterial curve down. So you can see the one free cell on the right side. That should return. That tells us the commissural alignment is good.
3 cosby.
빨리 안 하나? The reason why I hurry up is that always when we put the device in the annulus, the blood pressure declines. But now it is okay. Let's test it. Level is good, and commissural alignment is good. Thus, I try to release the first phase up crown, slowly. Yeah.
Blowing. 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 Blowing.
Okay, test. Yeah, up crown is released. The marker is at the level of annulus, a little bit high. Then I a little bit push the system with withdrawing the wire. Test again. Then release the arch. Start.
Blowing. Blowing. Blowing.
Gentle push and release slowly. Test it. It's good. And cine. Here is the position. That's good. And
So
final.
far, so good.
Pacing on.
120회.
Rapid release. Stop.
Good.
조작. Then I retrieve the wire to make the shears at the center to avoid the scratch of the shears and the frame. Okay, maintain wire. 오케이, 캡처. 저장하고. Okay, maintain wire. Yeah, you can see the 3 posts are equally distributed. That means good commissural alignment. The center post is behind, just opposite to the right sinus. Right one corresponds to commissure between right and left. Left one post locating commissure between right and none. Thus, in Ricard's view, when you see such kind of distribution, the commissural alignment was perfect. Okay,
Actually, the procedure is successfully done. When I look at the hemodynamics, is that the pacing rhythm or not? We want to know about
Pacing rhythm.
Yes, please.
Sometimes the patients show complete AV block, or
So
sometimes
please show us
rhythm cover and
what is
first
the
AV block.
happening after the acute neo complete AV block or not? That is the important issue in these cases. Temporarily stop the pacing and the ECG complete AV block or not. Please
As I
show us.
mentioned before, this complete AV block was before ballooning. Okay?
Just a little bit second. Please show us. Why not?
Okay, stop the pacing. 40. Okay.
And then something wrong and the pacing, start pacing.
Now the spontaneous first degree AV block.
No second degree AV block.
Complete.
No second degree AV block. Mobitz, Denkerbach. 3-2.
If you insist that we have to more monitor,
Well, can't you say? Okay. 맞춰봐.
and could you show us the extreme RAO view?
This is
Because,
a
this is-
2-1 block. This 3-2-1 block.
In this view, is a valve is a well expanded,
Induction.
but
can
the
pick one
underlying the valve is heavily calcified, so the possibility of a symmetrical expansion is not maybe.
Here is a 4-3 block.
Yeah,
Can you trace it?
Yeah.
This is the Denkerbach. Dr. In, do
Yeah,
you agree?
agree.
Okay.
But
자,
intermittent,
let me
right?
show you the angio. 89 years old male with baseline AV, first degree AV block, sometimes complete AV block, now high degree Denkerbach block.
Okay.
Okay. Sit. There is some regurgitated paravalvular leakage. Can you see?
Yeah.
Yeah.
Okay.
In
LAO,
the left cusp,
LAO.
maybe because of
Yeah,
the
post
underlying
dilatation.
calcium.
다시 아래로 가보다. 이집 안
Extreme
되겠네.
RAO.
When you see the RAO view, you have to see such kind of finding. One post on the right, two posts on the left, meaning perfect commissure alignment. Right one post located in commissure between right and left sinus because it is right and left sinus overlap view. Isn't it? That's central. In any way, we are going to do post-ballooning for show. Okay.
It is not the extreme RAO view. Before the post balloon, when you find out the very severely narrow vein portion, and then in the same image you do a post dilation, we can clearly see how expand the effect of the post dilation.
Extreme area view is not necessary. Just
Okay.
cusp view
Go
is
ahead.
good because we decide balloon size already. Even though it is not further expanded, you don't touch anymore. Okay?
Okay, go ahead.
23.
The diameter is 23. So,
Yes.
So you use 23 balloon.
What is the percentage in your practice in the post dilation in the when you're
About
using the
50%?
accurate nail?
About 50%. So the upper mark should be around central post to avoid damage of the leaflet suture, pacing, inflation, deflation.
You did the post dilation in the the view in the well expanded valve. So in this view, I cannot clearly determine the
Change.
valve is the effectively
Yeah.
dilate or not.
Minus. A little bit expanded.
Where? Which direction? Where In the upper side or lower side, where?
Both sides. Okay. So I changed to pigtail to avoid the bias from the stiff wire.
If the echocardiogram is available, and show us the echocardiographic finding at this time,
한줄 먼저 한번 볼게요.
of course.
So change to pigtail. Thus, we would like to see once again angio after change of pigtail and the ballooning. Okay. So then,
Decreased.
audiocarder remarkably changed by two factors: change of stiff wire and ballooning. 너무 높다. Trivial regurgitation. Let's see the echo. AP 주고.
In this time, when you look at the aortic pressure in the hemodynamics, did you see the diacritic notch clearly in the aortic pressure? Presence of the aortic notch is an indirect sign of the no significant paravalvular leakage or aortic regurgitation.
You are flushing the pressure line. Well, good. It is pacing beat, but it's good. Okay. 자, 에코 보여주고.
Yeah. Yeah, we can appreciate the diachronic notch.
70,
Yes.
118, 58, 20, 160, 116, 60, 20.
What is the diastolic pressure before the TAVI procedure? The currently is the 59, almost with 60.
60, yeah.
What is the diastolic pressure before the TAVI?
40.
Okay. Did you see echo?
Yes.
Trivial,
Yeah.
arterial regurgitation, parallax at 3 o'clock.
And the cardiography shows that there is no paravalvular leakage, and
좀
also
에코
the
내려줘.
short axis view, the valve is well opposite and roundly, and also from the Doppler view, there is no PVR. Okay, thank you.
I'd like
One
to
sec-
comment about the echo image. Somebody who attended the TAVI live yesterday, we did the eyes.
Longitudinal.
Image quality. You look at this is a
color?
transthoracic image.
Can you see there is no regurgitation, at least in longitudinal axis, a little bit oblique? Okay. We don't need imaging specialist in TAVI procedure because we are already accustomed, trained to see the image with our hands. Thus, it is very difficult to recruit image specialists at the time of TAVI procedure in all hospitals in Korea because all doctors are very busy. Thus, I'm not sure your system is ideal. It's not practical. Okay? What's the reversing flow at 4 o'clock?
I think there is a coronary flow.
Coronary flow?
Yeah.
Okay, coronary flow.
I
little
have
bit.
some suspicion is some
Yeah,
color flow
at 4
at the 3
o'clock, we
o'clock.
can see 3 or 4 o'clock, we can see a little bit
Oh, are we tracing that?
image.
I think that should be a trivial parallax.
Okay,
Yes,
trivial
yes. I can tracing that
tracing.
to the LV side, and there is a little probability
Okay,
from the
that spot continues to LV ventricle, suggesting it is paravalvular leakage.
Yeah, yeah.
Thus, with TTE, by interventional cardiologist, we can exactly assess the post-TAVI status with TTE. No need ice, okay? Anyway, we don't touch anymore because we already perform post-ballooning with average diameter and, okay, angio, good hemodynamics, minus angio. And as you can see, 여기 angio 틀어줘야지. First, I'd like to remove the ventricular catheter and finally check the root arterography. The reason why there is a privilege of accurate neo in terms of AV conduction issue is, as you see, the first release is just upper crown, no touch LVOT. Second process, just arch, no touch LVOT. Then, before low crown expansion, the valve system is coaxially aligned with aorta because of arch deployment. Finally, expand the low crown. That expansile force is not so severe. After final release, expansile force at annulus is the same between accurate neo and evolut. But difference is evolut starts from LVOT with very great opening force. That may predispose to scratch injury to LVOT, leading to complete AV block. But this is completely opposite. Upward deployment, finally just slight touch, LVOT. No AV block, even better than Sapien. Thus, this is a beauty of accurate neo, and then we can clearly see the commissural alignment. Then at the final 15 or 10 minutes, after you go to the Yamamoto and return, I will show you the angiogram.
Considering the patient age, your procedure is successfully done and wonderful cases, and congratulations.
Congratulations.
Do you want to see me engage the coronary artery
No,
later?
no.
Later.
Later, okay.
Thank you.
If coronary angiogram does not fail to,
Should not
it
be
is
an
a serious problem. So it should
when do
be
you return? 10 minutes later?
100% done. So we don't know. We don't want the waste of time to see that.
No.
We'd like to move.
I have a right to do
Okay.
live for 45 minutes, okay?
Everybody expects.
그래. 아직 안 들어왔나? Okay, then I will show you the 10 minutes live additionally. Actually, I'd like to show you my first CTO case that is successfully ended, but you probably don't know the story of my first CTO case.
Okay, good.
That's to show that coronary angio is better for this panel. Okay, being prepared for the angiography, I will show you the CTO case.
Go ahead.
Yeah, this is the end image of the previous live demonstration. So I performed the wire reverse cart, the antegrade wire knuckle and advanced, but it was wrong Thus, we got to know the retrograde tip injection plus. Then I redirect retrograde wire to the calcified CTO segment plus. But it's very calcified, thus it is impossible to UV3, miracle 6. Then I finally chose Gaia third plus near to antigrade wire plus. Then finally entered antigrade guiding catheter plus. Then externalization and anti-ballooning plus. This is angio after anti-ballooning plus. We were able to save big OM and septal branches because of retrograde approach plus. This is final angio after 3 stenting from LAD to distal plus. We were able to save the large diagonal branch and septal branches plus. Then after removal of retromicrocatheter, we assured the safety of corkscrew epicardial collaterals. 3.5? 야, 이게 안 된다, 그지? 이걸
들어갈.
뒤로 해야 돼, 보통. 오케이.
So,
I will show you the coronary angiography after accurate nail. (3.5) 너무 적지 않을까? 오케이. 플러시.
아이치.
3.5 너무 적지, 그지? 자. 이게 말리거든, 3.5 같으면. 내가 한번 핸들링 해볼게, 어떻게. 자, 4가 있으면 4 주고.
if you take too long time for the cannulation after this valve, is the advertise the disadvantage of this valve. So the quickly, very fluently, is the advertise for this valve.
Not advertisement. This is a live demonstration course. If I do well or not well, it is educational, good information for the audience. Because as shown, we compare 3.5 Judkin left or 4 in this case. 나도. I always prefer the remaining of the
Coronary.
wire like
Wire
this.
is coronary.
No, it is a curved wire. Don't worry about it. I always use guiding catheter because we can check the engagement. But he gave me the diagnostic catheter, thus I could not check the engagement. Flushing. 오케이. 저장하고.
아이치.
됐어? 오케이.
Good.
오케이. 됐어. 자, I see. There's one lesson is in this system, 3.5 is not necessary. In every system, small coronary catheter is preferable, but there is no frame above the coronary artery. Thus, you have to choose appropriate size depending on the ascending artery. It's very tortuous below. 안 보인다.
Dr. Kim, we will be back, and I have a request from the Japan. They are waiting for the finalized all patient, and they changed for the next cases.
가이딩을 달라고 했는데 또 다이노스 주네. 오케이. 이 라이트는 제대로 나온 라이트인가? 지난번에 아산다이브 할 때는 아노말러스 오리지널 RCA였는데. 테스트. Where is it? High or low? RCA? 그 전에 보면 이제 루트 아웃기를 보면 테스트.
Okay.
There's always the coronary arteries above the upper crown, usually. Thus, it is beauty of accurate nail to engage coronary artery. Not easily, but not so difficult. Of course, it is easier to do a naive coronary artery angiography, but it is not so difficult even after accurate nail implantation.
Okay,
Can you
excellent.
decrease the pacing backup rate to check the conduction system? 30. Three to one block, Denkebacher. Two to one block. Two to one block. Two to one block. Four to three block. Can you recognize prolonged PR prolongation and finally non-conducted? This high degree Denkebacher AB block. We don't know. He suffered from the repeated syncope. Thus, we may need a pacemaker implantation.